So, what if the root of your chronic pain, anxiety, or fatigue isn't in your joints or your brain, but in your gut? I'm Dr. Tammy Penhollow, a joint and spine expert. And in this episode, I'm joined by naturopathic physician MaryK Geyer to uncover the hidden world of the microbiome, how trillions of gut microbes silently shape your mood, your immune system, even your perception of pain. If you're struggling with inflammation, brain fog, or mystery symptoms, you don't want to miss this eye-opening conversation. Hit play. Your gut might be trying to tell you something. So I'm so proud to welcome Dr. Geyer. And I want to tell you that I met her in a networking format, and she just stood out as a person who I want to collaborate with and send patients to, because she's known for kind of taking on the stuff that nobody else understands in the complex cases. And that's often exactly what you need when you're dealing with pain. She is the founder of Empower Integrative Health in Scottsdale, Arizona. She's practiced for over 19 years in a whole bunch of different medical settings, including teaching naturopathic students. She has worked away from the sick care model. She recognizes that doesn't work, and her focus is health care. She uses individualized, integrative, and human connections to establish this. Without further ado, Dr. MaryK, please introduce yourself and let's get started.
Thank you so much for having me. I'm super excited. So I've worked in a lot of settings, and you and I were talking about this ahead of time, that we are living in such a cool age that the science is finally catching up with a lot of the things we suspected, and a lot of the things that have been kind of like poo-pooed by the conventional paradigm. And now we're catching up with wonderful research, and we know so much, and we're really bringing in more of this holistic healthcare and individualized healthcare, and starting to veer away and look at these things at much closer glance than we have in the past. So this is a cool time.
I completely agree. And speaking of like up close and personal and much closer, we're talking down to the microscopic level on today's topic. So can you just take a step back though from the microscopic and give an overview of, for somebody who maybe not even familiar with the microbiome, or what are you talking about? You're saying I have bacteria in my gut. Isn't that bad? Isn't that why we take antibiotics? Kind of talk to us about what is the microbiome 101, and we can dive a lot deeper.
Yeah, for sure. It's funny because you and I went to medical school and probably high school, and we came from this model where bacteria were the bad guys and viruses were the bad guys, right? And then we were like, oh yeah, we have trillions of them in our gut and they might actually help us. And it turns out that mitochondria might actually come from them. But we're not really going to talk about that, because we're taught that bacteria is bad and we're going to give an antibiotic. And that's the algorithmic medicine and medical model that we come from. And so it's evolved, and it's evolved quite a bit in the last 15 years and 10 years and even 5 years. And now it's just booming. And now we know that the gut microbiome is this ecosystem, and it's not just the gut. I mean, we have a skin microbiome, we have microbiome all over, and they're really keeping us healthy. They're keeping us safe from invaders. They're helping us digest our foods. They're helping us make neurotransmitters. More recently, some studies have shown that they're talking to our cells, and the cells are talking back. And that's like the coolest thing. Is like, whoa, wait, your bacteria in your gut and your microbiome are talking to your cells. And so now we've got this whole other realm of like thinking about people's guts and how we need to take care of them as the second brain. It really, we used to say, oh, the gut's the second brain. And now we're like, no, the gut is the second brain. It's where we start every time. It really needs to be the foundation.
What would be an example of that where the gut bacteria are talking to the cells? As advanced or as simple as you want to say it?
I always think of when I'm sitting with patients and I see a lot of irritable bowel syndrome, irritable bowel disease. I see a lot of chronic pain patients who have like POTS and dysautonomia and dysregulated immune systems. And now we know that we knew, but we know more, that the gut is really where a lot of that starts. So we're thinking, okay, 70 to 80% of our immune system is in our gut. And we know that because it needs to be our first stop so that bacteria don't get past that. And so I sit with these patients and I see every symptom under the sun come out, and they're saying, could this really be related to my gut, that I have pain in my joints? And now we know, yes, there are specific strains that are associated with IBD, and there are specific strains that are associated with rheumatoid arthritis, especially new onset. And so those are gut bacteria that we're looking at, and they're doing so much as far as our mitochondria and a mitochondrial dysfunction. And so this ends up being really messy for a lot of the types of patients that I see that are chronic complex, where We used to describe it. I don't know if you ever heard this analogy, and I hope you don't mind me rambling, but my colleagues love to use this analogy, and I actually kind of hate it, is an onion. And they'll say, like, well, you got to peel back the onion. You got to get from one layer to the next. I'm like, I don't see those patients. Like, I see the one where you go to the jewelry box and it's like all bracelets and earrings and necklaces all together. We're just kind of like trying to tease it apart. But ultimately, we have to start at the gut, because no matter what we do, if they have a mast cell issue, as an example, like a lot of times we're looking at mast cells for anybody who knows MCAS, and it's like, well, mast cells grow up wherever they are sent. That's where they're growing up dysfunctional. A lot of those people, it ends up in the gut with these inflammatory things. So it gets incredibly complicated. It's kind of like a rabbit hole, but we can simplify some of it just saying, like, well, we know this is our immune system, and we know that neurotransmitters are made there, and we know that the vagus nerve is in charge of our immune system and our nervous system and our gut. And so now there's this intersection between them. So that's generally the approach I take with patients when they're sitting there saying, I don't get it. And some of it we have answers for, and some of it we don't, right? It's evolving. That's science.
So do you specifically treat somebody different if, say, they come in with osteoarthritis or a chronic pain syndrome that is due not to an autoimmune thing, versus somebody that comes in and they've got, let's just make it simple, the gut issue like irritable bowel or ulcerative colitis or Crohn's, which may have a component of the autoimmune? So will you still say we're going to look at what your current microbiome is with some testing, and then we're going to go down this pathway? Or do you kind of hit everybody the same way because we want to start in one?
Well, everyone is definitely very individual. And so when I talk to my patients, like every single time, I'm asking about their diet, and I'm asking about their bowel movements, and I pull out my Bristol chart, and we're talking about all those types of things. So how I approach it might be a little bit different if they're having upper GI symptoms or lower GI symptoms. Not everyone's going to get a gut microbiome test, but I also don't order the same gut microbiome test for everyone. Ultimately, most of my patients will get their gut tested at some point with whatever I think they need. It's really about timing for many of them. Like a good example is I see a lot of people, they'll come in, they'll say, oh, I saw this functional med doc and they did a food sensitivity panel on me. And I'm like, this is absolutely useless. Like, you have the worst, like, your gut is not intact. So this is not going to be accurate. Whether or not you call that leaky gut, which I don't love that term. I feel like it's really thrown around, and you might agree with that, but intestinal permeability. And so there's a time and a place for each test. And there's also a time and a place for different testing. So we've got PCR, we've got microscopy, we've got culture and sensitivity, and each of these different ones. And then we've also got custom probiotics now, which is a whole other new realm of testing to have people make individualized probiotics for their gut. And so I'm looking at them similarly and differently simultaneously when I'm looking at somebody who has like a pain syndrome versus an autoimmune syndrome. Because I'm also looking at the immune system, and I'm thinking about, are we looking at the intestines being inflamed? Is there a gut bacteria that does not belong there? Is it a dysregulation at a different level? Do we need to calm their immune system down? So those are all a little bit different in how we do that and which order I'm going to order tests in. So I'm not going to order gut microbiome test on every single person, but I would say at some point, many of my patients do, because they really want to optimize.
Nice. Thanks for breaking it down like that. I don't know if this is a big rabbit hole, but do you go all the way back to birth history in terms of knowing that C-section versus vaginal delivery and the little bit of draconium or little bit of something that you get as you pass through the vaginal canal versus the kind of gut in somebody that was born via C-section, and how we can follow those kids all the way through? Is that part of your complex history and root cause analysis?
It used to be. I used to ask that for every single patient. Now I could really spend 3 hours with a patient, but ultimately I have 90 minutes with them, which is still a lot of time. Now I ask them when they come in, every new patient, I say, tell me about how this started, how it changed over time, and how it is now, including any workup, anything that we tried. And then I kind of trace it back depending on their history. So if this is an irritable bowel disease patient, I'm going back to birth. If this is an irritable bowel syndrome patient, that's different, especially if they developed it at 33 years old and they had food poisoning. That's a little bit different of where I'm looking at that. And the difference from where I was 15 years ago when I asked about their birth history is that I didn't have access to, none of us had access to the types of testing we have now. And so now I can just test that. It's kind of like, a friend of mine is an OBGYN and she's triple board certified. She's brilliant, but she doesn't do breast exams. And I thought that was really weird. I was like, why don't you? And she's like, I'm going to do a mammogram anyway. And I'm like, I never really thought about that, right? Like, we have all this wonderful testing. Maybe I don't need to go all the way back, because what I'm really interested in is how it is now. And so those nuances may or may not have been fixed. Yes, we definitely know, like, vaginal birth versus cesarean birth. We know that we're colonized right off from the beginning. We know it's important if they were breastfed or formula fed. Ultimately, most people, when they're coming to me 40, 50, 60, 70 years old, have a wildly complicated history. And so that's not necessarily my starting place with them. Now, kids, I see a lot of complex kids, and I definitely want to know their birth history, if they have like neurocognitive issues or if they're neurodivergent, and delving into some of those pieces. And I also tend to do genetics on almost all my patients. And so I'm overlapping genetics with a lot of those things, because we know methylation in the gut, methylation issues. And it's a lot more than just an MTHFR gene, which a lot of people are starting to talk about. And that's cool. But I'm like, that's two genes. Like, we're just talking about two genes, when really we could talk about 5 other methylation genes that are really important as well, and all kind of talk to each other. So yeah.
Good. Other things that people talk about, and maybe one of the first times they've ever in their entire life taken a probiotic is after a course of antibiotics, because they hear that taking something for otitis media or pneumonia, or name that thing, cellulitis, and somebody says, maybe you should get on a probiotic so you don't get a yeast infection. Can you break that down for a patient of why we would even talk about something like that, and what's the stepwise fashion that you would even yield the yeast infection after an antibiotic course?
Yeah, I'm going to try and like unpack this a little bit, because I feel like there's kind of 3 questions in that. And one is, thank God we're finally starting to talk about probiotics after antibiotics. And we know that we need to replete the gut, and that's so super, super important. And then we've got the other super important topic of antibiotic resistance, which you and I are acutely aware of. And I'm seeing more and more every day. It's really a little scary for some of these patients that are antibiotic resistant. And so we're looking at that, and chances of them being antibiotic resistant are raised if they're not completing their antibiotics and if they're not repleting their gut. So we've got a couple of those pieces. And then we've got the yeast infection topic, which is like a really fun topic for me, just because we tend to talk about this and say, okay, well, you might take an antibiotic and then you're going to get a yeast infection. And nobody really thinks about where that yeast comes from. Like, where did that yeast come from? Like, it doesn't magically show up. It's kind of like the take your tonsils out and you no longer get strep topic, which is like one of my favorites, where I'm like, it's a bacterial infection. Do you think you don't get strep any longer? That's not how that works. It doesn't just like magically go away and you don't get it. You swallow it. That's what happens. Like, that's different. So for my yeast infection specific patients, I'm often going back to birth if they've had chronic yeast infections, because that's the first time we're exposed to yeast, is when we're born through a vaginal canal or our mom has yeast. Sometimes we'll get yeast that way in the vaginal canal. Now, the other topic is I treat a lot of interstitial cystitis, which is chronically inflamed bladders. And so those chronically inflamed bladders, they're often unresponsive to antibiotics, and it feels like they have UTIs constantly, but they'll show up negative on their urine tests for UTIs. And then we don't necessarily like in conventional medicine, there isn't a lot, especially what's covered by insurance. It's like, okay, we'll do lidocaine and we'll inject it into your bladder and do a installation of lidocaine. It's like, okay, we'll numb it for a little bit. That's great. But when I'm looking at chronic vaginal or chronic urinary infections from that, I'm always looking at the gut, because people sometimes forget that there's like this much room for a woman. It's very easy to get cross-contaminated. And then you also have to look at the partner and cross-contamination. And so I'll run expanded urine IDs and expanded vaginal IDs a lot on patients, and they'll come up with 6, 7, 8 different types of infection. And then I'll be able to say, okay, well, we thought this was a yeast infection. That's what we were tackling this whole time every time you had antibiotics for. We thought this was a yeast infection you were getting every month right before your period, as many women tell me over and over again. And it will turn out that there's like bacteria and maybe a couple of BB strains, and then there's yeast in their vaginal canal, and they'll get it in their urine too, which we now know is not sterile like we were taught. And then I'll run a stool panel and I'll find that they have the same strain. So ultimately, kind of getting to the root cause, like you were talking about in the very beginning, when I'm looking at those patients, I'm looking at how do we treat the bladder, the vaginal canal, and the intestines and those strains so that they don't get cross-contaminated, being thoughtful about the fact that some of the strains maybe should be in the large intestine. And so we don't want to eradicate those, or we might create some more problems in the long run. And so it gets a little bit messier there, but that's the short and the long of kind of how I'm thinking about yeast infections and repletion, and people with chronic yeast infections or bladder infections or those types of things. Is again, we're looking at what bacteria belong there and what don't.
Right? It's not just so simple. Here's an antibiotic then I'm going to give you this probiotic, and no, I'll go ahead and prescribe you diflucan because that's the way it happens, because you're going to get your yeast infection. There's so much more to it, and that's Band-Aid medicine. And that's reactive medicine, and you're talking about proactivity and prevention and actually getting down to the root cause so it's not dealing with anymore. So thank you for that beautiful example.
Yeah.
So another topic that people talk about when they say the gut microbiome and the second brain, literally, and you've mentioned numerous times neurotransmitters. Can you draw the line, the connection between the gut and the brain, and talk about even serotonin receptors within the gut and those things, and how in the beginning I said anxiety, depression, brain fog? Connect the dots there.
Yeah, for sure. Again, kind of going back to what the public thought, what I thought before medical school. And then I think what I learned and then unlearned and then relearned again, as we often do, because we learn things for our boards and then we're like, am I going to use that? And then you're like, no, you're using that. I'm using this all the time. Is that we think 70 to 80% of our serotonin, upwards, some, we don't know exactly. Some say upwards of 90% of our serotonin is made in our gut. And that leaves 5% made in our brain and 5% made in our peripheral tissues. And so we're having a different conversation. Is it 40 to 50% of dopamine made in our gut? And that's made in the small intestine. And so when I'm looking at these things, like when I look at patients who have anxiety and depression as an example, is we saw this huge surge during COVID. I don't know if you saw that, but I saw a lot of people coming in with anxiety and depression. And part of it was circumstantial, and part of it was all these other things that were happening, and sleep disturbances, and them eating junk and feeding bacteria that weren't great in their gut, as an example. But portions of that is also just looking at, are they absorbing their nutrients? Are they making their neurotransmitters? Neurotransmitters are made from our diet. Everything's made from our diet, right? So you and I have talked about that in the past, is like, we make thyroid hormone from our diet. So why are we talking to patients about, oh, you're hypothyroid, it's not autoimmune, you're going to go on a thyroid medication for the rest of your life? And the first thing I'm thinking is, why are you not adding an iodine onto a tyrosine to make T3 and T4, which takes cofactors from our diet? And what I'm looking at, is it a dietary issue? Is it a malabsorption issue? Or is it something else within there? Like, a lot of people have messy guts, and chemicals in our environment are messing with our gut. So it gets a little bit more complicated. Or is it, again, a dysbiosis in their gut with that piece? And then we're looking at the endocrine system's a little bit more complicated, because we're always looking at the hypothalamic pituitary axis and how those end organs are kind of talking to the brain and back talking, and how that conversation happens in both directions. And now we know the gut is involved in that, which makes everything a lot more complicated. So yeah, that's how I'm thinking about those types of patients. Another thing that happens a lot is I see a lot of depression, right, in patients who have GI issues. And so, of course, they don't have the neurotransmitters. And what do we do when somebody has gut issues that we can't figure out? We give them antidepressants, right? That's like our first, like, you're going through menopause, here's an antidepressant. You're having gut pain, here's an antidepressant. And it's like, okay, well, that is helping to a certain extent. And it's helping because of those receptors, but it's not getting to the root of it at all, right?
So pivoting just a tiny bit based on what you just said, going through menopause, going through menopause, going through menarche, are there certain times in the cycle of life where there are influences based on the hormones that are either ebbing or flowing or completely declining, that you see changes in the gut microbiome?
I don't know that I made that correlation directly. However, I have seen very much the gut microbiome influence in the opposite direction, how we're metabolizing our hormones. So that makes a big difference of whether or not, when we've kind of packaged up our estrogen to go out in our stool, there are bacteria in the gut that actually can cleave that, and we can recycle our estrogens. And so I'm seeing that a lot in like perimenopausal and postmenopausal. And then of course I see it in younger women with PCOS and endometriosis, where they'll be constipated and then they'll have very high estrogen levels. And so as soon as we get them being able to have normal bowel movements, their estrogen levels drop. And so you're like, okay, that's wonderful. That's, again, gut bacteria, back to kind of the crux of it. Yeah.
I love that. Thank you for drawing the connection there. I was Always curious about that. I don't want to dance around this one any longer. You led us straight into it with talking about feeding the gut microbiome. And by what we eat, we determine what kind of bacteria predominate, which ones survive, which ones don't survive, which ones that should maybe not thrive or thriving. So, what's the role of an anti-inflammatory diet? Or you can just name some other things, but let's talk diet and microbiome.
Yeah, lots of thought processes on the diet right now, right? I mean,
Yeah.
not that there haven't always been these camps of like, this is the diet, we should do keto for this, and we should do carnivore for this. And it's a little bit more siloed, I feel like. People are getting a little bit more maybe extreme with some of the diet stuff. But we do know that like fiber feeds gut bacteria and it feeds good and bad gut bacteria. So a lot of these diets are helping us in different ways. Some of them are, there's the lectin-free diet. And so there's inflammatory chemicals that fruits and vegetables exhibit to protect themselves in nature. And so there's this thought process of if it's doing that, it's causing inflammation in our body with lectins. And so there's the lectin-free diet, there's the AIP diet. I think they all kind of serve their place. I use a lot of therapeutic, short-term therapeutic diets, although in my experience, I feel like over the years, I've seen entirely too much orthorexia. And so what I try and do is foster a really healthy relationship with people and food. And I tend to use things very more short term if it's a limited diet in any aspect. Also, the other piece of that is, for example, I see a lot of small intestine bacterial overgrowth. And so most doctors hate treating this because it's a really complicated thing. It's very difficult. We're talking about different types of bacteria, hydrogen bacteria, methane, which is technically an archaea, but we like to call it a bacteria because it works. It's easy for people. And then hydrogen sulfide. And I'll see people who have been limiting themselves with food because everything makes them sick. And so they're in all these groups and they're doing FODMAP for years and years. And what ends up happening is that these bacteria become smart and resistant to those types of diets. And so it ends up working against them because when I talk to them about different types of diets, I no longer have the ability to do things like elemental because it's been used to being starved out and it's already learned to hide in something called a biofilm in our gut. And that kind of opens up another topic, but it's like this lipid or the slime tent where it just hides out and it protects itself so we can't see it. It'll come out whenever it wants to. And so some of those diets, when done long term, can actually be a little bit detrimental. Carnivore is an interesting one because it really just removes anything that could be inflammatory for the most part. And so that works really well for a lot of people to reduce their inflammation. Then on the flip side, we know that our gut bacteria need fiber. So that's not something I generally recommend long term to people. Again, therapeutically, many of these diets can work and work very, very well, but it's all about strategy. And then for me, it's also just about people really creating this healthy relationship with food and this healthy relationship with lifestyle changes. Like I use baby steps to the market. I say it all the time to my patients because I'm just not an extreme person. It's like, yes, we know ultra processed foods mess with our gut microbiome and make us sick, and all of these things get worse. And at the same time, if somebody has no access to any food in that particular moment and they're really hungry, are they going to eat something? Yes, maybe that's the only choice that they have. So I think that's really important. And also to not alienate people in this process of where they're at in learning about these concepts. Because I mean, 20-year-old me was drinking about 2-liter bottle of soda a day and drinking an entire pot of coffee every single day because I didn't know any better. So I don't really expect everybody to know better, even though there's more information out there.
Great. Showing the grace. I mean, that allows you to connect with somebody because they know that you're not up here speaking down on them. You're meeting them where they're at. And let's say where we can bring you up together, right? It's fantastic. A little bit of a switch, but it's kind of a hot button right now. When we talk about the peptides with the GIP and the GLP-1 agonists and how they're actually in the gut. And when people, I mean, hearing, well, instead of getting on one of those things, the Wegovy's, the terzepatides or whatever's, then how about you just get the right probiotic that turns on your GLP-1? Can you talk about that?
Yeah, I actually recommend these a lot. That's cool that you brought it up because we do know, I mean, there are several different food sources. There are herbs, there are probiotics that turn on that GLP-1. So I really do like to start there with patients, and it gives them a really healthy option for it. And then we're also repleting their gut. It's got the Akkermansia strains in there that many, many people are depleted on. That can actually help with a lot of other things, especially here in the Southwest. Akkermansia is associated with allergies. And so we have a lot of people with high allergies, and I'll give them that and they'll say, hey, my cravings went down, which is cool. And then my allergies also got better. And you're like, that's fantastic. That's the strain that can sometimes be associated with those types of things. So there's a little bit of that cross piece with it. The appetite control is measurable for a lot of people from doing the specific probiotic. And there are a handful of them out there. There's one particular brand that does strain specific, which I really like quite a bit, just because they're looking specifically the strains for RA. They're looking specifically for the strains of Parkinson's. And so that's the one that I use for my GLP-1 patients that want to use a probiotic instead. And I mean, it definitely works. Now, is it going to be tirzepatide? You and I both know it's not. That's not how that works. They're not going to get constipated from it. They're not going to get nausea from it, but they're also not going to drop like 50 pounds in 4 months or something like that on a GLP-1 probiotic. But pretty consistently, they tell me it curbs cravings and they feel better on it. And so that's fantastic.
Are you seeing, as so many of the manufacturers claim, that there are reductions in A1C, which is also one of the big reasons to go on a GLP-1 agonist?
With the probiotics, I don't know that I've seen that yet. So one thing I do with every patient when I'm doing some weight loss with them, or we're working on like metabolic syndrome type things, is I use continuous glucose monitors a lot. And I monitor them on my side, and then they're monitoring on their side. And then I'm teaching them how to combine their foods and pay attention to the way that the curve is. So they can see, like, continuous glucose monitors. You and I have seen them, but somebody watching this may not. It's going to read continuously, and they're used for diabetics. And mainly in the past, they've been used for insulin dependent diabetics, even though now we're getting a little bit smarter with that. But we want to see kind of a gradual slope up when we eat something and a gradual slope down, and for it to maintain. And what often happens is that there's these high peaks instead, and it'll go lower on the other side, and they'll get hypoglycemic. And they might ride this roller coaster as their body's trying so hard to normalize and keep them in balance. It'll go like high, low, high, low, high, low. And then that's one of the things that tirzepatide and semaglutide can actually flatten that curve for diabetics. And so when I have my diabetic patients who are on those, or my patients with metabolic syndrome or other ways that I might be using some of those classes of medications, their line is pretty flat. And so when they eat, it kind of gradually goes up and gradually goes down. And that's what it's supposed to do. With the GLP-1 probiotics, I'm seeing some of that, but they're making so many diet modifications that it would be unfair to, like, correlation is not causation, you and I both know. And so it's like, well, is that the diet modification? Because I've already taught them how to read that and say, oh, I'm going low at night. I need to eat a tablespoon of peanut butter or 2 tablespoons of something protein before bed. How does that affect me during the night? Or during the day, I've had people be able to, like, eat the exact same things in different order and flatten their curve. And so that makes such a big difference, not only for their blood sugar, but also for the weight loss.
That's nice. Do you think that everybody should be on a probiotic? It doesn't matter. It can be a very individualized one. And I want to dive into the one that you talk about that are custom. But do you think that in this society, you can talk about the US and don't have to extrapolate to the world, that we need probiotics?
I think most of us do. I know this is a very controversial opinion. I've had lots of my colleagues say, that's ridiculous. You should just be eating fermented foods and eating fiber and all these wonderful things. And I think it's just gotten more complicated. So 30 years ago, sure, our soil was different. Our laws were different. We know the laws have changed quite a bit since 1970 in how they're monitoring and everything with our foods. And so that has changed. Our pesticides have changed. Our endocrine disrupting compounds have changed. And so there's so many, our nutrients are depleted. They don't carry as many nutrients. So for a lot of my patients, I used to say, like, if I could, I would put everybody on a probiotic, a fish oil, and a multivitamin. I don't necessarily take that approach any longer, because I often do run a lot of their nutrients and have specific things. And so I'll put them on therapeutic doses of single nutrients a little bit more and bring them up quickly, and then teach them how to maintain with diet and maybe a multivitamin in the background. Now, that being said, probiotics, I love them. There's so many things that can mess with our gut microbiome. I wish it was as simple as I don't take antibiotics now. It's just not. It's like my water has microplastics in it. My water has arsenic in it and hexachromium, and it has, radium, all sorts of things. Environmental Working Group, have you looked at their water database? It's scary. It's really cool. And I use it a lot to teach patients, because they could just put in their zip code and see what's in their water. And I'm like, you're drinking your water out of the fridge, and it's not cleaning any of this out. So those are things that are messing with our gut microbiome, even when we're trying to do our best. So you just control what you can. But a probiotic is super helpful.
And how do you tailor it? Because I know that there are ones that can cost well over $100 a month.
Yeah.
There are ones that can be a few dollars a month. There are ones that need to be refrigerated, not refrigerated, etc. So how do you meet the patients where they're at with regard to their budget as well as what they've got going on?
If I don't know any better and I'm kind of trying to be thoughtful, like as far as their gut specifically, and I'm trying to be thoughtful about how much money they spend, I usually go for a company called Claire. They have something called Claire 10, and it has really high in the billions. They actually put more in there than they state, which is really important. I am always looking at quality assurance data for these companies. And so that's super important to me is it's, if somebody can't report that and if they can't show third party testing and certifications, I'm not using them with a 10-foot pole if I can help it, because who knows what kind of heavy metals and whatever else was sourced from where. So I'm trying to control for a lot of that, but that's a really good one. I take their Biotic Complete quite a bit, and I often have people rotate the types of probiotics that they take. After antibiotics, there's one called HMF Replete that's from Canada, and it is very high billions. In the past, I've used VSL3, which kind of went off the market and I believe is back on the market now just because you can do 100 billion organisms for 1 week afterwards. And so that's one that I'll often use after an antibiotic. If I am at the testing stage to figure out exactly what they need, there's a company called Flore, really cool company. And they also, you don't need to, they have two different types of testing. They have one that doctors can provide. It's better, but they also have a direct to consumer test that even though it doesn't test as much, it doesn't give them as much, people can just go direct to the company and get that one. And that will test their gut microbiome and give them a probiotic. And then it gives them a prebiotic for afterwards and gives them directions on how to take those. And that's a really cool one, especially when I'm working on healing up the gut after like these long protocols where sometimes with SIBO, patients are on and off antibiotics for quite a bit, or they're on continuous antibiotics of like rifaximin or perhaps neomycin is another one that's used along with it a lot, or some doctors use things like metronidazole, which I don't tend to use for that, but we really focus on it. So when I'm doing some gut healing or I'm working on somebody's gut, when I do the treatment, I always test afterwards to make sure the organisms are gone, which I feel like is missing from a lot of people. It's kind of like the urine test. Like, do we really keep getting UTIs or was it just never fully treated? Same with vaginal infections, right? And then we spend 3 months healing up their gut afterwards to make sure it's fortified so that this doesn't happen again. So they're not going to get reinfected and they have a healthy gut.
It's a full circle of care. And so I appreciate that. I know we've kind of touched on it, but because so many of my listeners, viewers are pain focused, can you talk about the microbiome and pain and what you found? And you can talk, some of them do have a autoimmune, but just in general, pain and the microbiome, can you touch on that?
Yeah. I mean, we're kind of going back to those same things of looking at the gut. So when I'm looking at somebody's gut and I'm looking at their fibromyalgia or their rheumatoid arthritis or whatever, I see a lot of patients in like the lupus and Sjogren's and mixed connective tissue disorder realm, or patients with Ehlers-Danlos, where that's not going to go away for them, but optimizing things does make a big, big difference. And so what I'm looking at then, I'm usually looking at any kind of gut symptoms. Again, kind of I'll run tests for upper GI and lower GI, or two different tests. I think sometimes people really get confused about this if we're looking at the upper GI and lower GI, which you and I know pretty well, but this isn't their world. And so if I'm looking at like burping, reflux, bloating, gas pain, that gas can be upper or lower because small intestine, large intestine, diarrhea or constipation are mixed, can be upper or lower. Where things like reflux, we're looking at the stomach, we're looking at the duodenum. We're trying to figure out what's going on in the small intestine there. Because of its location, being so close to the diaphragm, oftentimes they'll have shortness of breath or chest pain. And then if they also have these symptoms of pain, oftentimes they're very weird pains, like they're wandering, they're electrical, they're different types of pains. And so we're like, oh, it's fibromyalgia because it's wandering. It's like, is it really fibromyalgia? I'm looking at their gut bacteria. I'm looking at maybe small intestine bacterial overgrowth or fungal, large intestine, and then also their beneficial strains. And I kind of have a hierarchy of thinking when I'm treating guts of where I treat, like small intestine takes a while to treat, so I often treat the large intestine first. And I see a lot of parasites, which I do not treat parasites personally without testing. I'm a big test person. And so, but I do see them come back positive on tests quite a bit. And so I'll treat parasites first, large intestine bacteria, I'll do a little replete the gut before we enter into small intestine bacteria. Fungal I'll treat all along because as soon as you take their competitors out, fungal loves to overgrow. And I'll do that a couple different ways. And we can do these things with pharmaceuticals when we can do them naturally. We just have to be mindful of how we combine those, and do they need to be monitored, and do we do a short term of a pharmaceutical and a long term of a natural, and then we do that kind of replete the gut piece for them. Now, when I'm dealing with a lot of my pain patients outside of the gut, I'll often use low dose naltrexone. It's very, very common, and some pretty high like bromelain, curcumin type supplements that can help quite a bit with that inflammation. But I love low dose naltrexone. It just kind of calms the immune system down. I mean, we have so many studies now, and then there's a lot of other things that we can do as well. But that's kind of how I look at it and the way that I describe it to them. So again, it does get really complicated, which you and I know, but we have to keep it simple and distilled for patients. So we kind of take that stepwise approach for them. And ultimately, we're optimizing. And sometimes we have to start with one segment and then the next. And then we need to make sure that they're fortified at the end and that their microbiome is like fortified with that piece. And so that might be where at the very end, I do a flore and see what strains they have and what we need to replete specifically for them, rather than just putting them on a generic probiotic, along with things like low dose naltrexone. So yeah, that's some of the things I'm thinking about. Now, there's also, we didn't talk about it, I do think it's important to touch upon. For some people, they do have food sensitivities. And again, I test. I also personally do an elimination challenge because that's the gold standard. And so I have them take things out and challenge them so they know what their responses are. I'm not going to do that until they have a healthy gut. They shouldn't come back with 50 different foods. And I test IgGs and IgAs and explain the difference between an allergy and a sensitivity, which really is another pet peeve of mine being thrown around. Like, I have allergies. And I'm like, you're not allergic to that. You don't get hives and anaphylaxis. You don't need an EpiPen. Like, that's very different in IgE for that particular patient. So that makes a big difference for their pain syndromes. And a lot of times we can get rid of many medications just taking away their sensitivities because of those immunoglobulins and pro-inflammatory cytokines. And then the other piece that I'm looking at is that I'm seeing more and more patients with non-celiac gluten sensitivity. Again, testing. I don't diagnose these things without testing, where I think a lot of people will say like, well, I just avoid gluten. And I'm like, that's great, but I really would like to know, like, we're not sophisticated enough when we're looking at non-wheat proteins to select a bread that has that particular non-wheat protein, but it's helpful to know how complicated it is, how severe it is. Can you eat breads? How often? Can you eat different versions of breads? If they're imported, does it even have to do anything with non-celiac gluten sensitivity, or is it the fact that it's a fortified grain and you have a methylation issue? So that's again where the testing kind of comes in and simplifying it for them.
That's great. Thanks for breaking that down. So I think we've touched on a whole bunch of different topics, and I'm glad we have. I kind of want to summarize and put it in the camp of what's in it for me. I'm a patient. You're telling me about a microbiome. What is in it for me to even care about my microbiome, to even care about getting them probiotics? Am I going to benefit in, and I'll feed a couple. Am I going to have decreased pain? Am I going to have better sleep? Am I going to maybe even change some of my medications? Because guess what? Now that my gut's healthy, I'm going to be on a different dose because it's actually being absorbed. Tell me some of the best things and what's in it for them and why should they even care?
It's huge. I tell patients that they're kind of investing up front when it comes to naturopathic medicine or functional medicine, right? So they're coming to us. We're going to do a lot of testing. And while it might feel like a lot of testing or might feel expensive or might feel like a commitment to them, what ends up happening is instead of them on this long road of like not getting answers and spending, I've had people come in and they've spent $300,000 in the last 2 to 5 years with functional medicine docs and other conventional anywhere trying to get answers. And it's like, well, you can invest in this test or this testing and we can get you feeling better faster. And so when I'm looking at a patient, so if I have a healthy patient that's just looking to optimize, that's a very different scenario. And so we're going to optimize, and I'm really going to teach them about food and lifestyle. And I'm still probably going to run genetics on them just because I'm thinking about kind of like biohacking with their diet and with their lifestyle. And I'm looking at their cardiac genes, and I'm looking at their weight maintenance genes, and I'm looking at their methylation genes, and I'm looking at their vitamin genes, and I'm overlapping that so I can see why they've been anemic their whole lives when they're a male and they're not menstruating and they didn't get surgery. And like, there's not these reasons for them to be anemic. That's going to do a little bit different, but it's an investment up front for them to feel better in the long run. And then it's kind of like for me working out, I'm not working out to look like a supermodel in my 50s, right? Like that's That's not my goal, but my goal is to not get a hip fracture and to be metabolically fit and to be able to lift my groceries at 70. And so those are my goals with those things. And that's how I'm thinking about people that want to work preventatively. And even with my chronic complex, I want to get them relief. I try to get for them really quickly. So I expect to see results in 6 to 12 weeks, or I'm not doing something correctly. Unless SIBO is a whole other like little thing because they just feel terrible with SIBO and it takes a little bit longer. But most other things, I'm kind of looking at 6 to 12 weeks for them to start feeling better. And that means their joints and everything else. So whatever we're focusing on for those pieces, they should start to feel better. And then I usually give them a realistic timeline, or I try to as much as possible, because I'm a very transparent person. And I also want them to be able to say like, okay, I'm spending this now. What's my expectation? And my expectation is that that person's going to come in at maybe 3 to 6 months. When they're not coming in every month to see me, they don't need to. They're going to get better and their symptoms are going to get better, but they're also going to be empowered in their own healthcare. So they're going to know when to see me. Like my patients now, they'll be like, oh, by the way, I had this, but I knew what to do because you taught me last time. And that's what I want to see. Like, I don't need to see your sniffles and your flare. You already know what to do for your flare and whatever it may be. So
Fantastic. Thank you. Anything else that you think we have not touched upon that we absolutely have to?
I think I just want to re-emphasize, I know I feel like I'm beating a dead horse, but this is so important because I actually just had this conversation before I came in here with another doctor. So it's fresh in my mind about testing and the importance of testing is that there's a lot of people, there's a lot of information out there. There's also a lot of misinformation, and more than ever, like I have people bringing in Chat GPT, like treatment plans, and they'll be like, well, this is what Chat GPT said to me. And I'll be like, okay, well, it's not always accurate. And you can put the same thing in there 3 different ways. It'll give you 3 different answers. So there's definitely a place and it's beautiful, but there's a lot of misinformation out there. And there's also a lot of people who are kind of desperate in their healthcare and they're talking to each other in these chat groups and trying all of these things. And so, I mean, there are doctors like you and I who are out here who are exploring, and they're all over the US, and we might be like kind of hidden gems, not paying a ton of money for marketing like some of them are, but doing the testing, being really responsible, because not everyone influencers, and I've seen some really irresponsible health coaches recently and some other things, people calling themselves naturopathic practitioners that had, one of them was educated in a house locally, like not a school, but like a house. And so she was calling herself a doctor of natural medicine. And so somebody thought that that was the same thing. So I would encourage people to educate themselves, to advocate for themselves, and to also be like cautious and skeptical with the information out there. Is that, yeah, you can get anything out of ChatGPT or TikTok or Instagram, but it's not all accurate. And so due diligence. And I mean, I encourage all my patients to question me. Feel free. Like I tell them, go do your own research. Come back to me. What do you think about this? Like if I don't know the answer to something, I don't know the answer to something, I'm going to research that. None of us can know all the answers. I mean, I do like 10 hours of research every single week and I can't keep up with the studies, right? It's just too much. So they're going to bring stuff to me I haven't even heard of. But that's what I would say is like those pieces. And then the last little piece, sorry, a little ramble, but the last little piece, which you and I have talked about, is when people want to function within their insurance, they really just need to understand that the insurance company is going to dictate what we do behind these walls. And while we try and control that as much as possible, the insurance company and people who are non-medical completely are dictating the way that we deliver healthcare. And so in order to get something different, they often have to go outside of that. And I think they get this idea that because I am no longer in network with insurance, that I'm like making boatloads of money. And that's absolutely hilarious. It's not the case at all, right? It's extremely expensive to run a practice, but it also doesn't dictate the time that I'm with them. So I'm able to have good staff. I'm able to handpick those staff. I'm able to choose their experience for them. They can spend 60 minutes with me. I can give them the best medicines, but they also think oftentimes that it's just too expensive. One, we often say like, well, not investing in your healthcare is really expensive, right? Like that cancer down the line and some of those diagnoses, and that is true. But on a more simple level, we know where to get things that are less expensive for them. And so oftentimes I end up saving patients a ton of money, and they don't necessarily realize that because they don't know that they can go outside of their healthcare. They don't know that they could pay $25 for an x-ray or $250 for an MRI that they just ran through their insurance and still ended up paying $680 out of pocket for. So there's a lot, there's compounded medications, there's GoodRx, there's all these things that we have access to that are actually going to save them a ton of money in the long run. So yeah, there's just more resources out there that you should really be aware of and keep researching.
Absolutely. Empower the patient, invite questions, and know that we really do have your best interest at heart. And we do. We have a lot of different resources, saving thousands of dollars by using self-pay on labs or through going through something like an Avexio or using, yeah, all these things. It's fantastic. So thank you for putting an exclamation point in that. Awesome. So, how do people find that? I will put everything down below. So, don't pull over and start writing if you're driving, but we'll put everything down below. But how do we find you? How do we work with you?
My practice is Empower Integrative Health. We're at Princess and Perimeter in North Scottsdale, and our website is empowerintegrativehealth.com. Also on Facebook and Instagram as Dr. MaryK Geyer. So on Instagram, it's dr.MaryK Geyer, and Empower Integrative Health also on Instagram. I also have a YouTube. I don't foster it and tend it very well, but it does have some interesting videos on there if they want to go look at like an IgG versus an IgE versus an IgA. I break those down, or if they have things they want me to break down for them, I'm happy to do so. They can always shoot those to me on Instagram or Facebook or a comment on YouTube.
Awesome. Dr. MaryK Geyer, this was amazing. And I think there's probably going to be a round 2 in the future. But please, if you've got any questions, ask them below. If they're specifically for Dr. MaryK, then I will direct them to her. If they're specifically for me, then I will answer them. And thank you so much.
Thank you so much.
If you have knee pain and would like to learn more, I have a worksheet called 5 Things to Do Now to Reduce Your Knee Pain Within a Week. Go to www.kneeboostnow.com to download it for free. I'd love to hear from you, so please like, subscribe, and comment below so I can help you get out of your knee pain.